And there are some associated medical conditions like steroids, et cetera, can make you more prone to develop type 2 diabetes. So what happens is you develop insulin resistance. So this is a graph just showing that in the early years, so this would be diagnosis of diabetes. Even before you get diagnosed with diabetes, you can see insulin resistance increasing. But at a point that plateaus. Now the beta cell is very clever. It has some plasticity to increase its output of insulin and then also to grow somewhat in response to the increased insulin resistance. So it'll get bigger, it'll produce more insulin, and it'll do this very well for a short period of time. So this is a normal islet. These are mouse sections. This is from a pregnant mouse. So you can see in the middle of all the stress, the islets can grow. So they can overcome that metabolic stress test, if you will. This is a mouse that we gave a high-fat diet. So a normal mouse gets about 17% of its fat from its diet, or 17% fat from diet. If we give about 42%, you can see the islets grow like that. But unfortunately, this can't go on forever. So what happens is a beta cell initially will compensate, may grow, it'll increase its insulin output, but over time, insulin levels will fall. So if a person has had type 2 diabetes for many years, they can look very much like a type 1 diabetic who has no insulin at all. And that makes it very difficult to manage in the clinic sometimes. So what causes the beta cell to fail in type 2 diabetes? Well, high levels of glucose, high levels of fatty acids, and then these factors called cytokines can really cause a number of stress pathways to be activated, and then eventually you get really the beta cell just stops functioning well, and you actually lose beta cell mass. And this is just a graph showing that if you look at that in human patients, you can see even in obese patients and lean patients, you can see a loss of beta cell mass here and here compared to patients without diabetes. And this is a measure of cell death. So those are increased in diabetes. So how do we prevent type 2 diabetes? Well, it's important to think about what a normal body weight is. And I put a BMI chart in your folders. I think that Catherine made copies of that, and you can kind of see where you are. We'll talk about BMI in just a second. So we can all eat better. I just had a cookie and 2 servings of Chex Mix, so I mean we all can do better. We're supposed to get 30 minutes of moderate exercise every day. Weight loss if you're overweight. And this is not losing 100 pounds or losing 10 pounds or 100 pounds or 50 pounds. Really, if we can encourage patients to lose 5 or 10 pounds, that can make a big difference in how their body responds to their insulin. And then I put being a good role model to the next generation, and why is that? I'll talk about that in a second. So this is a tool we use in the clinic called body mass index calculation. So it's basically kind of putting you into a category, and we know that when your BMI is less than 25, that's pretty good. That's normal. If you're at 25 to 29, we call that overweight, and a BMI of 30 is obese. So if you're in that over 25, that means that your beta cells are not going to be able to produce enough insulin to keep up with the demand on them. And certainly when you get to a BMI of over 30, that's a real stress to the beta cell. And the reason I said be a good role model to the next generation, so I don't know if you guys have seen this recent report. So a lot of military leaders put together this report, and the title of it is Too Fat to Fight. So I think they estimated that like 75% of our youth would not be able to get into the Army or the services at this point, which, if you think about it, puts it it's a national security risk. And about 20% of children are obese, considered to be obese. So that's a big factor when you think about these people are going to be more at risk for diabetes. They're going to have diabetes for a lot longer as well. So how do we treat patients? Diet and exercise, obviously, that's the most effective. Sometimes if things aren't so bad, we can give you oral medications, but a lot of times people go on insulin. Pancreas transplantation and islet transplantation are potentially ways that we can cure the disease. And then further down the road, but something we think about in the in the research arena is that if we could engineer a beta cell in our research lab, or if we could make existing beta cells grow, then that would potentially be a good treatment. And regeneration, so being able to affect that immune response. And I just wanted to kind of show you what we try to do with patients who need insulin when we're treating them. So there are really kind of two components to our plasma insulin normally. There's a basal component here, and each time you eat, the pancreas normally produces big spikes in insulin. So what we do is we try to mimic that really with insulin injections. We have patients take short-acting insulins with each meal, and then we have them take a longer-acting insulin, like a Lantus insulin. I don't know if any of you have heard of that, where you get this basal component. But really what we're asking people to do is inject themselves about 4 times a day, which is a lot. I know it's a lot, and I know it's a lot to ask people to do. We also ask them to check their blood sugar, sometimes upward 4 or 5 times a day. So that is a big burden on the patient, and one that we certainly understand. That's a lot to do, it's a lot to carry, it's a lot to think about before you eat, etc. Now, one really revolutionary thing for diabetes has been the development of the insulin pump. And that's what it looks like now. So it's really no bigger than my pager. This is another form here. Some of them are controlled by a handheld device. Some of them are controlled just on the, something like this where people can punch in how much they get. And there's a catheter that's tunneled under the skin, and that delivers insulin. This is what the insulin pump looked like, sort of the first prototype. Could you imagine wearing that on your back? I don't think that would be very useful. And then one other thing that's been developed are now we're using them in patients are continuous glucose monitors. So another little device that looks like an insulin pump that will measure glucose continuously in the bloodstream. Sometimes we use those for patients who are really active, and it helps us kind of manage their pump. Other times we might put it on a patient for 3 days or so and get an idea what their patterns are and make changes based on that. And so this, you can just see this is a person's blood sugar over a day. You can just see the different curves here. And that data is...
Monitor also inject insulin to keep it at a constant level, or just monitor?
Well, so unfortunately, if you have a pump and a continuous glucose monitor, you have 2 things on your belly. So you have the monitor that will be continuously sampling, and then you can have the pump that would be, but they're separate right now. Okay. I mean, there's a lot of research going into creating an implantable pancreas substitute, but that's only been done in research at this point. So that's kind of not a good glucose monitor. You see a lot of kinds of ups and downs. This is one, actually I borrowed this from a PharmD who works with us at the VA. She has type 1 diabetes, and she has a pump, and she's very vigilant about her blood sugars. And you can see that, she does have some excursions, but really she's within this sort of sweet spot here. So she works very hard to maintain her blood sugar. And it's a constant battle for her, though. It is a hard disease. So sort of down the road, things that we think about on a research level are how can we improve the lives of patients with diabetes by replacing their beta cells, making new ways to give insulin, and one of those is, that I'll talk about in a second, is some of the research that we do in collaboration with Dr. March's group. So we do a lot of diabetes research in our lab. We do some type 2 diabetic projects, we do some type 1 diabetic projects, and then we're starting a project looking at some of the cardiovascular complications of diabetes, so thinking about heart disease and diabetes and what factors can cause that. So in type 2 diabetes, we're really looking at why does the beta cell fail, and one of the really useful tools that we have is this mouse model called the DB-DB mouse. And so this is an obese mouse. Mice aren't normally this big. This is one earlier on, and then they just continue to gain weight, this particular model, because they don't have a hormone that tells them to stop eating. So what's interesting about this model is that they look very much like a person with type 2 diabetes. So these are their islets at about 8 weeks. You can see them losing islet mass at 10 weeks. At 12 weeks, they're down pretty low. But they're a very good tool for us to look at a number of different things about type 2 diabetes. this is a schematic of the beta cell, and I'll share you the gory details, but just tell you that it's a pretty smart cell because it can sense blood glucose continuously, secretes insulin to match that when everything's working well. And so one of the things that we're very interested in are some of these calcium pumps that regulate calcium. Calcium allows the insulin to be secreted. And we see that in type 2 diabetes, the level of gene that encodes those calcium pumps is very low. So we're looking at how these things are regulated. One of the research projects that we do is we are looking at a diabetes drug that's approved called pioglitazone. We're looking to see what effects it has on the beta cell itself. And it does seem to prevent that loss of beta cell mass that we see in type 2 diabetes. And one of the ways we think it's doing this is by activating these calcium pumps. We're also doing a number of type 1 diabetic projects. And so one of the things that we're looking at is, in the context of these stem cells, is islet transplantation. And so basically this is you take an islet from someone who's passed, and you take a pancreas rather, I'm sorry, break it apart, you isolate those islets, and you give them back to a recipient. I'll talk a little bit about how that's done. So basically you break these apart. This is put into a chamber with marbles, essentially. They're a little fancier than that, and I'm sure they cost more. But it's heated, and you break it apart with this special enzyme. You separate out the islet fraction, and you give that back to a diabetic person. And so this is what it looks like when you isolate those pancreatic islets. So these are from a mouse. These are actually ones that we can obtain from people who've passed and donated their body. We can get islets from them as well to do studies in the lab. And what's nice about an islet transplantation is it's not an open surgery. So these islets are isolated, they're put in a small volume, and then they can be put in through a needle into the liver. And that's where they'll live and secrete insulin. Unfortunately, though, so far, the use of this therapy has been a little disappointing. So this is over time. These are months of follow-up. This is insulin independent, so patients who've received islet transplants, and you can see that over time, pretty quickly, they're not insulin independent. You can still measure some insulin in their blood, but it's not enough to keep them from having to inject insulin.
Is that a rejection phenomenon?
It's probably a lot of things, and the way that we've been looking at it is it's probably the cells don't normally live in the liver, so there are factors about the liver that make them not happy. So a lot of them will die there, and part of that maybe is they don't revascularize appropriately, and then they may need some extra growth factors to keep them alive. So what we've been looking at is potentially taking these adipose-derived stem cells. They are known to secrete a lot of growth factors. They're known to also help blood vessels grow, and see if they might be protective to the islets. So some of the projects that we've done so far are really kind of simple. So we're just seeing in a Petri dish, if you put them with the ASCs, do they survive longer? And they do. You can see these cells start to break down after some period. I think this experiment was done for 5 days, but the islets look a lot better when they're incubated with the ASCs. So we think the ASCs are supporting a number of factors to help the islets survive. This is just that same concept illustrated with some blue-green dyes. So if you think about, or I'm sorry, red-green, red being dead, green being live, you see a lot more red when you don't have the ASCs, and you see less red when you do. So we wanted to test that in one of those preclinical models that Pam talked about. And so basically what we did, so we treated some mice. These mice don't have an immune system, so they can't reject the islets. That way we can take out the autoimmunity factor, and we can look at purely what are these cells doing. So we treat them with this drug, STZ. It makes them diabetic. You can see that. We give them a glucose load, and we measure their blood sugar, and you can see it rising. And that's pretty high, a blood sugar of 400 to 500. That's with STZ alone. If you just give them an injection of the stem cells, you can see the blood sugar comes down pretty well. It almost matches animals who haven't been treated with STZ at all. So that's pretty encouraging for us, and we're following that up with a lot of other studies.